So what I want to talk about today is, or continue to talk about, is patient management and workers' compensation and some of the really key issues that underlie what we do. And to remind ourselves that really in many ways, workers' compensation patient management is not very much different from group health, other patient management we do. A large part of it is really reporting, but the other aspect is some consideration of causation. But otherwise, it's much the same. So we're not talking about two different types of business. Let me just make sure we're recording this.
Yeah, it's recording,
Okay,
Chief.
good. Okay. So having said that, what I want to talk about today is a couple of things. One is the fact that in workers' compensation, we're looking at not an open-ended business, but we're looking at something that has the start and a middle and an end. And what I want to talk about then is some aspects of that. And in workers' compensation, we initiate care. We recognize that something happened, an injury or an illness, and so we need to initiate care. And there's some decisions we make at the outset. And then there's a phase, which is the management of care, following guidelines that we try and get people as well as we're going to get them. And fortunately, in most cases, folks will return to their pre-injury status, how they were before the injury, but sometimes not. And then the final is the conclusion of care. And this is one of the differences between group health, urgent care, and workers' compensation. And that is workers' compensation care management is not intended to go on indefinitely. The goal is to get patients back to a state in which they're as good as we can reasonably get them. When they're stable, hopefully that's back to how they were before the injury. Sometimes it's not. But we have to be able to recognize that and conclude our active care. As we'll talk about another time, that doesn't mean care stops, because there can be provision for future care, but we have to recognize, be willing to recognize when patients are as reasonably good as we can get them. So we need to keep these in mind as we're providing care to patients. The second thing is, which applies frankly to all aspects of healthcare, whether it's workers' compensation, whether it's group health, urgent care, whatever it is that we're doing, we really should be developing plans. And when I review cases, when I get calls, there's not infrequently, we don't seem to have a plan. We just kind of go from one step to another, not certain where we're heading. And in healthcare, medical care, we should always be dealing with a working diagnosis. What do we think is going on? What is it we're treating? And then keep in mind differential diagnoses. What are other things that could be explanations or diagnosis for the problem? But everything we should do should be in relation to a working diagnosis. It's what we think the problem is, which can change if in the course of things, as we do treatment, we do diagnostic procedures, whatever we do, it may be that what we think at the outset is a problem really isn't the problem later. And so our working diagnosis may change. That strain of the knee may become an internal derangement, but we start off thinking perhaps that we've got a knee strain. So think in terms of a plan, and then there should be steps in the plan. You go from one thing to the next, and we're starting off with a physical exam and history taking, and there'll be some imaging, some x-rays, there may be some lab, there may be some therapy, there may be some specialty consultation. But where is it you're trying to get? Where do you think the endpoint is going to be? Again, treatment, the decisions about working diagnoses may change as you go, but have a diagnosis and avoid the temptation wherever possible to make your diagnosis, your working diagnosis, a symptom. So when we're treating something, we should be treating what we think the working diagnosis is, not necessarily pain. Now, there'll be sometimes where we just don't know early on. We don't have a really clear diagnosis, working diagnosis. And so we may use as our diagnosis a symptom, but try and resist the temptation to do that. Try and use a real diagnosis of a real condition that's your working diagnosis. So having said that, what are we going to cover today? I want to look back just for a few minutes at a piece that we talked about last time, AOE, COE, that is making a decision about job causation, about aggravation and exacerbation, and then look at first aid and the reports that in workers' compensation that we're responsible for providing. So AOE, COE. Who remembers what that is arising out of and in the course of employment? A patient comes in, you get a little post-it that says carrier or employer is requesting an AOE, COE. What are they asking for? We talked about this last time. What is it that they're asking us to do? Elray, do you remember what that is?
I remember what they stand for, but just something that states that we determine it is work related. So then it could be considered a work comp case.
That's exactly right.
Okay.
It's a decision. Good job. It's the issue of job causation. Is something job related or not job related? Is it a material change that constitutes a job condition or not? So they're asking us to decide, is something job related? And most of the time it's pretty clear. They walk in bleeding or they've got pain or something. It's evident to everybody that something happened on the job, but sometimes that's not the case. Maybe 10%, maybe 15%. And so we need to be prepared to make our best decision about something being job related or not. And as we've said before, in workers' compensation, nothing is in stone, nothing's in granite. Any decision you make can be changed or a requested change or alteration by the carrier or the patient. They can get a QME, they can take various steps. But all we're doing is we're making our best decision along the way. And when we make an AOE, COE decision, there are two pieces to that, two components. One is, did the presumed job event, whatever we think or somebody else thinks was the cause, did it make a material contribution to their impairment? Impairment being either a physical or mental abnormality. If they were symptom-free before the job event, before, let's say, a laceration, then they had no problem and they have the laceration. And so the impairment is the laceration and the material contribution is, yes, it's on the job. The job made a substantial contribution. And in the case of a laceration, was 100% of the contribution. So in an AOE, COE decision, we're making a decision about contribution. Is it material? Is it more likely than not? We may not be certain, but we're asking ourselves the question, is it more likely than not? Is it at least 51% likely that the event caused the impairment? And we use the word probable in the case of workers' compensation, and the word probable in work comp means it's more likely than not. The likelihood's at least 51%. There's a material contribution. Doesn't need to be the sole contribution, but it needs to be a material contribution to whatever that impairment is. And then the second piece of it is our level of confidence. We need to believe that it's more likely than not that that contribution is what we think it is. So it's not a jury trial. It doesn't need to be 12 jurors agreeing. We're just saying to whoever's asking about this, or in the first report, more likely than not, that's probable that the material contribution actually occurred and is significant. And with those two considerations, we make a decision, yes, job related, no, not job related. So there are a couple of terms that are significant. One's aggravation and one's exacerbation. And we talked about those last time. Carolyn, what do you recall aggravation to be in contrast to exacerbation?
Yeah, so aggravation is you have the problem, but then it gets significantly worse. So more like that curve in A. And then exacerbation is you have the problem, but it kind of fluctuates up and down with a little exacerbation getting worse, but then it gets better and get a little worse.
That's right. And that's true. And on the graph we're looking at, the significance of aggravation refers to, is there a pre-existing problem that's now made worse by whatever the job event was? And that graph, that line would be the C graph, because we're saying somebody's got a pre-existing problem, they're on the B graph, and now they've had a new event and they're materially worse. We call that an aggravation, and that constitutes a new injury, and that's the C line. And that can conclude with either the D or E line, but it's the C line. So their pre-existing problem is now materially worse. So there's been a material contribution to that impairment, and our level of confidence is that, yes, more likely than not that that's true. And so we call it an aggravation, and we call it a new job injury. And an exacerbation then is, as you said, it's the B graph, where their problem is just their low back pain, pre-existing low back pain is just waxing and waning. It's better some days, it's worse some days, it's better some weeks, worse some weeks. But it just tends to hover in sort of a sine wave in between two levels of severity. And they have an event that occurs to their back pain, but their back pain really isn't materially worse from that new event. It's still kind of hovering. It's going back and forth, waxing and waning between, in this case, the 5 and the 7 line. And that's an exacerbation. And that would be, that would mean that the event for which the patients come in is not job related. It's just their pre-existing problem. So we're asking ourselves, there's an event that occurs. Did that event make their symptoms materially worse or not? And so aggravation, yes, it did. Exacerbation, no, it didn't. Now, here's a couple of cases. Santiago is a field worker with a crew picking strawberries. His job is carrying boxes full of strawberries weighing 40 pounds to the trailer for transport to the packing shed. He reports lifting a box and felt acute pain in the low back. That's the event. He also reports chronic low back pain from a prior injury that never resolved, pre-existing problem. Following the recent injury, the new event, the pain worsened in his low back, but not more than usual. Now, that Santiago comes in, you get the post-it that says, AOE, COE, what are you going to conclude? What are you going to tell the carrier? What are you going to put on the first report? Clay, what would you suspect? What would you call that?
That sounds more like an exacerbation, because there's no more than the usual waxing and waning pain that he has.
That's exactly right. That's exactly right. And so it just, if we're going to manage it, whoever manages it, we indicate on the, we send in a first report, but we indicate that there's not a material change, that it's a pre-existing problem. And we just continue to treat it that way. Or actually, let me take it out. In that case, we don't send in the first report. We just manage it as a pre-existing problem.
Steve,
Yes.
when we're managing as a pre-existing problem, do we have to go back and find the original case, and that's what we're billing it to?
Yes, that's what should happen. Now, there can be some challenges to that. One is, if we were seeing the problem and we've got the medical record, then it's a whole lot easier. Sometimes they'll come in and it's a problem that somebody else was treating. And we may get some old records. Hopefully we do. The carrier may well send us a PR4 from a previous problem, or may have some other source of information. Other times we don't. And we end up having to make our best decision. And to be honest, just in those cases, about the only way we can make a decision is frankly to ask the patient, is this, what was your level of pain before, today's event? And what is it now? And, we have to believe, we have no other information than to believe in those cases what they're telling us. And so we draw our own conclusion, and we may well call it a new event and aggravation. Now, in those situations, the carrier, if they disagree, can get the patient's statement. They can put the claim on delay, and they can do their own investigation, look for old records. They've got 90 days to do that, and then they'll end up making the final decision. But on that first visit, or the visit following this purported new injury, we just have to make our best decision based upon our physical exam and whatever the patient tells us. And so we just use our judgment. And as said before, nothing is in concrete that we do. If the carrier gets more information later, then they may decide it's not job related.
So it sounds like on these visits, it's really important to accurately quantify the patient's pain level, the waxing and waning scale as best we can, right?
Yes.
Because I assume the carrier is going to go back and kind of try to find that pain scale in some other note somewhere, and see if there's a material change.
That's right. That's exactly right. And that's why in every injury, we should be asking if you had this problem before. And most of the time, patients say no. And sometimes they're not telling us the truth, to be honest. We may discover later, yeah, they had a pre-existing problem. Where this tends to arise, not to get too far into the weeds, but patients will sometimes settle claims without future medical care. They'll take a bigger settlement, and then they'll come back later, and they may come back under Medicare or Medi-Cal or some other source, or purport something to be a new job injury. So, it gets to be a little bit tough sometimes, but we make our best decision based upon the available information, and that's all we can do. So here's another example. Malcolm is a computer programmer in a local technology company. He has had symptoms of carpal tunnel syndrome for 7 years. He declined surgery, not uncommon, and conservative measures did not result in resolution of the symptoms. He remained stable. Recently, he moved to a new employer, underwent several months of programming, 12 to 14 hours a day. His carpal tunnel syndrome symptoms worsened substantially. He underwent hand therapy, splinting, and NSAIDs, and so he's worse. What would we call that situation? Who's out there?
Give an example of an aggravation.
Yes, and why would you say that?
He has his pre-existing carpal tunnel syndrome, but then which worsened more due to his increase in hours. So it's a increase in severity from his pre-existing condition.
Yes. And then as we embark on treating that, our responsibility is to get the patient back, not necessarily symptom-free, although that would be great, but get them back to their pre-existing status. So, excuse me, so that C graph then it becomes an E graph. In other words, they're waxing and waning at a higher level, and then with treatment, ideally, we get them back to their prior B graph where they're waxing and waning. So yes, this constitutes an aggravation because the pre-existing problem was made materially worse, and that's our best judgment based upon what the patient's saying. Now, first aid is an issue that comes up from time to time, and another decision we some number of times have to make on that first visit is, can this be managed as first aid? And in the work comp world, what that is a case where it's not managed as a job injury. It's an event, but it's not reportable. And so what we typically do is it allows the employer to pay for care for that visit or subsequent visits rather than the carrier paying for that. And in a second, we'll explain what the significance of that is. But what are first aid cases? Anyone, and this is quoted from the federal guidance, any one-time treatment and any follow-up visit for the purpose of observation of minor scratches, cuts, burns, splinters, other minor industrial injuries that do not ordinarily require medical care. This one-time treatment and follow-up for the purpose of observation is considered first aid, even though provided by a physician or registered professional personnel. So what are examples of that? Foreign bodies to the eye that we can remove, particularly conjunctival foreign bodies, that we can remove that they're not going to come back for. Or abrasions or scrapes. The patient goes back to the regular job. There's no modification, doesn't require any prescription medication. They can take over-the-counter medication, doesn't require the employer reassigning them to something that's called regular work. They have to be able to go back to their own regular job. What are not examples? Generally, back injuries, musculoskeletal injuries, wounds that require suturing, corneal foreign bodies, depending upon the circumstance, if you're going to see them again for that. So these are considered first aid. This is a relatively small percentage of the claims cases we see, but we can manage as first aid. And there's a spot where we indicate, and we'll show an example in a minute, of calling this first aid rather than a job injury. Now, why are employers interested in this? Well, their work comp premiums are based upon the prior 3 years of experience of aggregate cost of care. And so workers' compensation covers injury treatment, temporary disability payments, they're off work, permanent disability costs when there's a claim settlement, and death benefits. And so every injury, the costs are aggregated. And in the first year of a policy with whomever, state fund, whoever the carrier is, the premiums are based for that year on the number of employees, the job categories that are present, and a couple other considerations. And so employers start off at kind of a neutral position for the industry in which they exist. And then with each subsequent year, their premium can go up or down based upon those aggregate costs that accrue through the 12-month policy period. And if they have more injuries than average and or the costs are greater than other like employers in that industry, their premium costs are going to go up. And if their aggregate costs are less, their premium costs are going to go down. And in many employers, 5, 6, 7, 8% of their operating costs are workers' comp or is workers' comp policy. So for large companies, it can be very expensive. We have some employers out there that want to call things first aid because they're trying to minimize their cost of workers' compensation, particularly their policy costs, their premium costs. So we need to resist the temptation to call things first aid if they aren't really first aid. And if you have a case where this shows up and the employer is pressing you for it, and you're really not sure what to do, call Dr. Pricey or call me, and we can talk to you about it. The default position is a reportable claim, not as some employers would have it, the default being first aid. So we should be managing these as reportable injuries unless it's clear that it's first aid, not the reverse. And sometimes, we have the forms that we fill out, or the receptionist, whoever has taken the claim information, when the employee shows up, we're getting authorization. Sometimes there'll be circled or handwritten in on that page. You've seen that presumably. It's the contact information with the employer, and it'll say first aid. Well, that's not how the decision's made. We make the decision, the employer doesn't make the decision. And so again, if you have questions about it, give one of us a call and we can discuss whether something's first aid or not. Any questions about that? You seen that before? Any trouble with that? Okay. Now, where does all this get reported? And we're now running low on time, so I'm just going to pop through this quickly. But we have three types of reports in work comp we do. One's the doctor's first report. And you know that when you click on the initial visit here, let's see, I don't know if you can, let me see if you can see this. One sec. I'm gonna go to my pointer. Find my pointer. So so in any event, down at the bottom, there are, we're asked three questions. Is a patient's complaints consistent with injury or illness? We say yes or no, and that's essentially, is there a material contribution? History consistent with the objective findings, and then we make the decision. I hereby confirm with a reasonable degree of medical certainty that this is work-related, AOE, COE, and should file as compensation. And we have two other choices where they say no, if we're certain that it's not, or we can equivocate. And then the place what we should be doing is bottom left, DFR. This is, of course, right next to the diagnosis or options. Type in DFR, and that will signal to your scheduler or whoever is filling out these forms that a doctor's first report is appropriate there. Now, I've discovered that some number of our folks that are responsible for the DFRs know to look for that. But in any event, if you can type DFR in, then I would do that. The second set of reports, or a second report group, is the PR2s. And this is something we do when there's a change in status generally. And in the next slide, I'll show you the examples. And so in the similar box, options, bottom left, type in PR2, and that will bring up this screen. And reason for PR2, third line down on the left, you have choices as to why you're doing, you designate why you're doing the PR2. Patient's discharged from care, condition has substantially changed, a request for ancillary treatment's been submitted, request for a diagnostic study. So ancillary treatment may be PT, request for diagnostic study, maybe MR of the low back, specialist consult, change in employee work status, they're now going back to regular work, or periodic report. If we're not doing it otherwise, we should be doing these every 6 weeks. And then in that case, click on other, and you may choose to write a comment in. So periodically, when the employee's status changes, we should remember to send in a PR2. And then finally, the PR4, and I just want to hop through this because in an upcoming time, we'll talk about this in more detail. There's more to this than we can really discuss in a short period of time. But when you do the work status, the PR4 is done when you're ready to discharge the patient and they're not fully recovered. They've got some residual impairment and or there's some permanent disability. And so the operant medical term is maximum medical improvement. The administrative term is permanent and stationary. They mean the same thing, which in the work comp world means the patient's not likely to materially change in the next 12 months. And so we think that they're essentially as good as they're going to get. And there's some residual impairment, that is physical or mental abnormality, and or there's disability. So those are what trigger a PR4. So we're doing filling out our work status. And then we're going down below at the bottom left, PR4. And you'll have this portion to fill out. And there are a series of checkboxes and some free narrative text to type in. What I'm going to be doing, we're going to be having an upcoming discussion, probably the fourth Thursday with John Alchemy and Rate Fast, because we complete these and then typically we'll send this off to Rate Fast. We're going to go into PR4s in more detail. But the thing to keep in mind is when you see patients that seem now to be as good as they're reasonably going to get, you've done everything you can reasonably do. They're just, your sense is they're not likely to change. They've seen the specialist if appropriate. They've had imaging if appropriate. They've had therapy if appropriate. Your sense is they're just not going to get any better. Then it's time to call them maximally medically improved and designate that they're permanent stationary, which means that the carrier can proceed to close the claim. And we're going to describe whatever the residual impairment or disability is. And bear in mind, patients at that point, sometimes I'll get the question and I'll explain to them, this is what's going on. We've done everything we can do for you. It's now time to close your claim. I tell them though, the doctor, provider is not, we're not closing the claim. Only the carrier can close a claim. What we can do is we can say, you're as good as you're reasonably going to get. You may or may not need future medical care, but there's nothing really reasonably more to do for you. We're going to indicate that to the carrier. We're going to send a report off. The carrier will contact you and discuss conclusion of the claim. And they'll settle it in one of a couple of ways to be discussed later. So you're never closing a claim. The carrier is closing a claim. You're only reporting to the patient and the employer and the carrier. They're as good as reasonably going to get. And we've done all we can do for them. We don't have anything more to offer unless part of it is future medical care. So you fill out this portion and this goes off to Rate Fast. Rate Fast generates a report, goes off to the carrier. And that's the basis for concluding the claim. And what you see here is just the second half. It's the lower half of the questions that you will be asking. So PR4, more to come later. But the takeaway for today is be alert to when patients are as good as they're going to get. This isn't group health. We don't treat them for the rest of their lives. We don't tell them, come back if you get worse, come back if you need me, that sort of thing. This is the last visit and we send this off unless there needs to be provision for future care. Any questions on that? Scott, any comments?
I do.
Sorry, yeah, go ahead. Who said that?
So, I'm gonna squeeze in Dr. Percy. Sorry. So for that PR2, Dr. Schumann, I have not dropped that order the way that you showed on the screen. I usually just do it through the work status. When you go to the work status through Epic, it says changing work status, and
right.
I'll just simply click yes to generate the change and for them to do the PR2. I haven't ordered it before. So are we supposed to be doing both?
Well, I'll tell you what I do, and Scott can comment.
Well, yeah, can I just say real quick, the answer is yes. Because that box you check in the work status doesn't go anywhere. It's just a piece of text that drops into the note. So the only way to order this through Epic so that somebody picks it up in the back office or front office is to actually then you check it in the work status and then you go down and you put it in the order and this box comes up and you fill this box out. This is the only way to get credit for the PR2. Go ahead, Steve, sorry.
No, that's exactly right. That was what I was going to say. And this also is the opportunity to indicate why you're sending the PR2 in, because you need to let the carrier know what the reason for it is. Now, what will happen sometimes if you've got really good work comp schedulers, they'll send in a PR2 because they know what to watch for. But this makes it crystal clear. So I would, if any of these circumstances that you see on the screen exist, then I would indicate what that is. You click on it, it's highlighted, and consider adding comments if it's appropriate. Any other questions about that?
I'm just going to note that's something that you'll probably want to bring up to all the providers because I don't think a lot of us are doing it that way.
Yeah,
Okay.
Shane, and I just put it down on my agenda for next week, so I'll mention it.
Good. Any other questions?
Just as like a reference, I would also bring up the first aid that you can have follow-up because I think most people believe that you can't have follow-up, and that's been my impression. So I think that would be helpful for everybody to know as well. Because I've had like a lot of those cases where I'm like, I just need to see you one more time. And they're like, oh, it has to be work comp. So that would be super helpful.
Yes, as described,
Right.
any one-time treatment and any follow-up visit for the purpose of observation. So that's exactly right. You really don't want to be doing probably more than 2 or 3 follow-up visits. If you're getting to that, this can be really should be considered first aid. And by the way, we can start off designating something first aid, and then if unforeseen circumstances occur, this can be converted into a work comp claim, a reportable injury. It's almost impossible, but it is impossible, essentially, to do the reverse, to call it a first aid, I'm sorry, to call it a reportable injury, and then go back later and make it first aid. But it's not difficult. And what's theoretically supposed to happen is we're still supposed to fill out the first report. It goes to the carrier, but we're designating it as first aid. I don't know if that's really happening, but that's the way it's supposed to work in the regulation.
That's another thing, Dr. Parcia, I would add because I've had the same situation come up where I've wanted to do something as first aid and then do a follow-up, and I've been told that I can't do a follow-up for a first aid.
Yep. Okay, I'll clarify that in the meeting.
Good.
Thanks for bringing those 2 things up. That's really
Yes.
good. Yep.